The rationale is pretty simple. The elderly population is quickly the fast-growing segment of the population, both in US and in Western countries. And because age is a major cardiovascular risk factor, elderly patients do have a very severe coronary artery disease much more often than younger patients. And however, they have been poorly studied in clinical trials, and even today they are still treated with bare metal stent to reduce the duration of DAPT and to reduce the bleeding risk. This is why we wanted to study latest generation drug-eluting stent together with a very short duration of DAPT to both get some benefit on reintervention without paying the price on bleeding. That was the rationale of the trial. The design was quite simple. We wanted to have an almost all-comers population. We designed a randomized clinical trial, single-blind. We wanted to concentrate on patients 75 and above with coronary artery disease. Inclusion criteria were quite simple. Patients have to be 75 and above, and they need to be either in stable angina with optimal medical therapy, or to have significant silent ischemia, being defined as more than 10% of the LV myocardium, or an FFR lower than 0.8, or an unstable condition. Exclusion criteria were quite limited to patients unable to comply with the DAPT, prior hemorrhagic stroke, bypass surgery, surgery within a month, and patient with allergy to aspirin and other P2Y12 inhibitor. The choice of DAPT was really, we decided to choose a BMS-like DAPT to reduce the risk of bleeding in this population, because you know that elderly population is not only a population at high ischemic risk, but they are also a population at high bleeding risk, much higher than younger patients. So we decided to go for a very short duration of DAPT, because basically this duration is what drives the physician to choose BMS versus DES in some of these patients to reduce the risk of bleeding. And therefore, in this trial, even the DAPT was not randomized. It was strongly suggested that the DAPT was tailored to clinical presentation. 1 month for stable patient, which is really a minimal, and 6 months for patient with unstable presentation at baseline. The results are quite simple. The MACE, which is all-cause mortality, MI, stroke, and ischemia-driven target lesion revascularization, were reduced in the DES group. This is 11.6% versus 16.4% in the BMS group, so a 29% reduction. The p-value is 0.016. The number needed to treat is 21, meaning that when you treat 21 patients, you avoid 1 MACE. Interestingly, the curves are still diverging at 1 year. And it was pre-specified in the secondary endpoint that we're going to look at 2 years analysis next year. In addition, about safety, this was the secondary endpoint. Bleeding are absolutely similar in both groups. BARC 3 to 5 are 3-4 and 3-5 in both groups, and stent thrombosis are not significantly different between the two groups. I think the message is quite simple. I think senior clearly demonstrate that latest generation Synstrat DES are at least more effective and as safe as BMS in elderly patients with short tailored DAPT. I think that the trial also suggests that BMS should not longer be used to reduce DAPT and to reduce the bleeding complications. This trial cannot answer for DAPT duration because it was not a trial centered on DAPT duration, and therefore I think it would be interesting to think about which patient should go for a longer duration of DAPT.